Hey, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckbill, and tonight I will be serving as your program facilitator. I will help present your questions for Dr. John Phu and Dr. Andrew Starr. These experts perform robotic surgery for hernia surgery, general surgery, including gallbladder and orthopedic surgery for knee replacements using specialty-specific robots. This evening, they'll answer your questions about this cutting-edge surgical technology, including how it works, the benefits, what procedures can be done robotically, what to expect during recovery, and much more. Well, thank you so much for submitting your questions in advance of tonight. And if you have any questions throughout our discussion, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A, and you can go ahead and just write your questions right there in the text box. Now, we'll do our very best to get to as many questions as possible, but may not be able to answer all of them during tonight's virtual event. And due to hospital university guidelines and privacy, we are unable to comment on specific cases or the number of patients we have treated or are currently treating. Likewise, if you are experiencing any symptoms that may require immediate medical attention, please go ahead and consult a medical professional. Finally, don't worry, we've taken the liberty of muting everyone's line to eliminate that annoying background noise. So feel free to move around and get comfortable. So with that, I want to give a minute for our physicians to say hello, and then we'll dive into our questions for the evening. So Dr. Phu, thank you so much for being here tonight. How are you doing?
I'm good. Thanks, Sarah. I appreciate having me here tonight, and thank you all for joining. I'm happy to be here this evening to talk about robotic surgery with Dr. Starr. Just a little background about myself. I grew up in Ontario, Canada, and I did my undergraduate studies in pathobiology at the University of Toronto. Then I went to Michigan State University for my medical degree. And then I came to Pennsylvania. I did a 5-year general surgical residency at Abington Hospital. I'm now in practice at Lansdale Hospital as a general surgeon with 3 other of my partners and colleagues who do general surgery as well at North Penn Surgical Associates.
Okay, well, thank you so much for that introduction. Dr. Starr, we'll turn it to you now. Welcome.
Well, thanks very much for having me here, Sarah. It's always fun to be here in an environment where we can talk to the folks in our community. I've been part of the community in the Abington and Lansdale region for over 30 years. I've seen tremendous growth in great types of technology that support our surgeons, our patients, and our community. So it's fantastic to be here, and it's something that for me, every year gets a little bit more exciting. So I really am looking forward to chatting about this a little bit, answering people's questions, and seeing if we can get some other folks who might be interested in learning about this.
Absolutely. It's going to be an interesting discussion for sure. So we're excited to dive in. Okay, without further ado, let's get to the questions. Dr. Phu, we'll start with you. Let's just keep it a little bit general right now. So could you just give us some background and explain exactly what general robotic surgery is?
Sure, Sarah. So general robotic surgery refers to the Da Vinci surgical system platform made by Intuitive Surgical. They're a medical device tech company based in California. And it consists of 2 components, namely 3 parts: a surgeon console, a patient cart, and as well as a vision tower. And these all together link up and talk to each other to allow robotic surgery to be performed. It's a type of minimally invasive surgery where surgery can be performed through small incisions through the abdominal wall. When we get to the slides, maybe talk a little bit more about the system itself. But it does refer to a surgeon console, and that picture there is the patient cart. And though it looks kind of scary, it is the patient cart arms where the small incisions and the robotic instruments go through to be in the abdominal cavity to perform the surgery. And it allows full articulation of the endowristed instruments which can bend and articulate far greater than the human hand. Next slide. So this is the three components of the Da Vinci surgical system. And so the patient cart is that middle image there, showing where it would be placed through the abdominal wall with usually 3 or 4 small incisions about an inch or less in size. And the console on the left is where the surgeon would sit. It consists of the vision camera where the surgeon is able to see the magnified anatomy as well as a 3D high definition picture. It consists of the finger clutches within the console itself to allow the surgeon to articulate the instruments, which communicates to the patient cart in the middle to do specific dissection. And the foot pedals on the bottom help control the movement and the direction of the camera, the focus, whether to use cautery and other types of functional modalities. And the tower on the right is the camera where things are connected to allow energy and the video system to run. Next slide. And that's just another view of what the surgeon or what I would look like when I'm at the console itself, where the hands would be at the finger clutches to do the dissection of the surgery, which directly communicates to the patient cart on the left there for the robot to do the procedures. Next slide. And just to give you a sense of how big these robotic instruments are, so that's a number 2 pencil on the right there, and those are some graspers on the left. And that gives you a sense of how big these instruments are, and they bend and articulate far greater than what your wrist is able to, but also can do very fine dissections with the high definition camera. Next slide. So to give you a sense, in open surgery, you have your full range of motion in your hand, and anything you're able to articulate or do with your fingers and hands is translated to the robotic instrument itself within the abdominal cavity with the robotic system. Next slide. And this is just a particular simulated view here where the finger clutches are taking the movements from the surgeon's hands and my fingers and translates it to the robotic arms to do fine suturing, fine dissection, and various other surgery techniques with small incisions. Next slide. So usually with these types of surgeries, it takes 3, sometimes 4 incisions through the abdominal wall. And the surgeon is in the room all the time at the console directly beside the patient. So they're not at some far location or at home doing this. They are within the operating theater with the patient at all times.
Okay. Well, thank you so much for taking us through all those photos. I think that was a very helpful way to kind of really see what's happening for a patient. So thank you. Dr. Starr, is there anything you would like to add from an orthopedics perspective?
Well, sure. I mean, and obviously our robots are quite different because our tasks are quite different. But the first thing I would like to say to the audience, because I've been in the room watching the general surgery robot, and it's a very interesting process. And I think the first thing people look at is they see all that technology in that room, and it seems kind of scary. These are big machines. It looks like something you might see on a movie somewhere. And I've actually had robotic surgery for myself, robotic general surgery, so I can speak from experience. I think everybody knows about laparoscopic surgery and how that, in orthopedics, that's arthroscopic surgery, make little tiny incisions. These technologies really allow us to do things that we couldn't do before. In the case of general surgery, that technology allows someone who would normally use a laparoscope, a little tiny scope to do some limited surgery, to do very precise, very extensive surgery. So, I'll kick this back to John to sort of comment on this, but I think what people need to understand is, these big machines are really designed because they're very, very accurate, and they can do very, very fine surgery. So we take what looks like the biggest thing I've ever seen in an operating room, and we create something that's tiny and minuscule. And I mean, I woke up after surgery and I couldn't believe I'd had surgery. So John, maybe you can comment on some of that because it looks kind of big and scary, but the precision, the accuracy, and the little tiny incisions that you guys make. I mean, I left the operating room with a few Band-Aids. Go ahead.
Yeah, Dr. Starr, that's quite accurate. I mean, these machines do look big in the operating room. It does give a sense of intimidation, but they do very fine and precise work. And we'll hear this word a lot of times, is that the higher precision done by these instruments, it allows us a more finer dissection. So even though they seem large and intimidating, the types of work and the dissection is very fine and accurate. What we do.
Yeah. Well, thank you both. And Dr. Starr, it's interesting to hear from your perspective of actually having the surgery. So thanks for sharing that.
I'd rather not, but I'd rather not have had the experience, but I have to say it was a very favorable experience. And literally, it's amazing because, people always ask me after total joints, like a total hip, they'll say, oh my God, that's in my body. Now, our surgeries are quite different than what Dr. Phu's doing, but they'll always say to me, wow, I don't feel that thing inside me. I can tell you my experience with robotic general surgery was that I woke up, they had done surgery, and I couldn't believe that they had done it. Not that these are totally painless procedures, because they're not, but it was amazing to think how much they had done. And you kind of look at your stomach and you have a couple little Band-Aids and a couple little cuts. So I give credit to them. And they were actually, these general surgery robots, I think were the first robots that really entered the operating room. Although orthopedics has now had them for quite a number of years as well, so in a very different form, which we can get to in a minute if you'd like.
Okay, great. A couple of Band-Aids. That sounds good to me.
Right.
Okay, let's dive into another question for both of you. So when is robotic surgery an option? And are there any reasons why robotics may not be an option? Dr. Phu, let's start with you.
Sure, yeah. So robotic surgery is an option for, in my field, at least for general surgery, an option in inguinal hernias and also abdominal hernias. For example, umbilical hernias, ventral hernias, or incisional hernias, where there has been surgeries in the past, people have developed through prior cuts from open incisions, and also for gallbladder disease, namely biliary colic or chronic cholecystitis. And these are the type of surgical diseases that the robotic system can be applied to be used to repair hernias or to take gallbladders out. It can be advantageous in recurrent hernia types where the robot would be able to do a dissection in a plane that's previously not been operated on. And that's typically the traditional teaching, is that sometimes you dissect in the plane where a prior surgery has been done to avoid difficulties there. And so it would be very useful in that sense. Bilateral inguinal hernias are a good option too, as well, for robotic surgery. You're able to address the left and the right-sided hernias, if they do have that, through the same incisions without additional cuts or more incisions. And so those are some of the pathologies that are good for robotic surgery in the general surgery world. They're appropriate. The robotic platform is good for small to moderate-sized hernias. Not that it can't tackle large hernias, although it could be more difficult for larger sized hernias. And so, open incision may be more appropriate in those candidates. So it depends on the clinical context. Robotic surgery would not be good for patients who would not tolerate general anesthesia. So that's the one caveat, is that with robotic surgery, you have to be under general anesthesia and totally paralyzed and relaxed. So if a patient's medical condition prohibits that, or has some type of problem where they can't be intubated, and so they wouldn't be a candidate for robotic surgery.
Okay, thank you. And Dr. Starr, any comments there?
Well, let me back up just a hair. Why don't we put up the slides that we prepared, just to get a quick look and kind of create an overview, because orthopedic robotics is completely different. And fundamentally, we're using robotics and orthopedics in two areas, in the area of knee replacement and in the area of spine surgery. I don't do spine surgery. I only do knee and hip replacement. So we'll focus tonight on really the latest robotics in knee replacement. So many of you may know, but I think it's worth taking a quick look at kind of where we came from. This is a knee replacement. This is still what they look like today. This is a plastic model. This was never a patient. And what you can see in this picture on the left is you have the white or tan bone, and then you have a metal cover on the top, a metal cover on the bottom, and a piece of plastic in between. And if you look on the x-ray on the right, that's kind of what it looks like when you come in the office and we take an x-ray. And it shows that the implant fits very nicely on the bone, very nicely on the covering the entire surface on the tibia and the femur bone, the top and the bottom, or bottom and the top, and then this plastic piece in between. And that makes up for the cartilage, which is the padding in between. Now, these operations require a great deal of precision. Let's go to the next slide. So these operations began in the 60s and 70s in the United States. And the way they were done was with rulers. I mean, we literally did a lot of measuring during the surgery. So we don't quite use a wooden ruler in the operating room because you can't sterilize it. But, we have rulers and we have these, what we call them jigs, which is what's on the surface of the bone. So once again, a plastic model on the left. You can see the muscles are kind of the red things around the outside. This is all plastic. And you can see that we have put this little jig, we call it, on the front of the bone. And it has little pinholes that line up with our other jigs. And so we can make measurements. You see this is measuring. If you look at the numbers on the right, we would say this is a size 5. We would then take a size 5 out of the box and we would put it on this patient's knee, and that would be how we would fit it. Now, robotics jumped into the scene about 6 or 7 years ago for knee replacements in an effort to give more feedback to the surgeon to try to make them more accurate. So if you look at the next slide, rather than having rulers and jigs like you saw before, these are what our robots look like. They're quite a bit smaller and simpler than what Dr. Phu's robots look like because they have a completely different purpose. And they're very computer guided. And I'll show you what I mean by that. So basically every system like this, you can see in the pictures here, has a pair of eyes, which is what you see on the top on that boom. There's 2 little black areas. And the robot on the left is called Rosa from one manufacturer, Mako on the right, which is the one that's been around for the longest. And they're all the same. They have eyes on the top. They can see what we're doing. They can then computerize that. You see they both have computer screens. And then they have the unit that actually does the work. And that's the robotic arm you see in the center labeled Mako, or on the Rosa, the console that says Rosa. And that can move. And as the computer sees what we're doing, we can adjust on those screens exactly where we want things to be put and make measurements. Let's go to the next picture. Now, these have been getting more miniaturized. This is the latest robot that we got at Lansdale Hospital. This is actually the 24th of these in the world. This is from Johnson & Johnson. But, I can't say one robot is necessarily better than the other, although this is more miniaturized, much smaller. But once again, you can see the same thing. You have the eyes on the top. In this case, it's a black bar, but it has 2 eye holes. And the robot's looking at what you're doing. You can see in the model in the center that it looks like there's kind of some bones on the screen. And they are. There's bones on the screen. And we can adjust where we want to put this implant. And the way that we do this is there's actually a touch screen that's sterile, which you can adjust yourself. I'll show you that in a minute. And then in the middle there, kind of parked up against the robot, because this one isn't deployed, there's actually a saw that we operate, and that's how we carve the bones to make that implant fit perfectly. So if you go to the next slide, you start to see some of the technology, and this is what I like about it. Because rather than have a ruler, these are actual measurements that we would get on each patient. And all of these numbers are angles and dimensions. On the right-hand side, you can see ligament measurements. And with this one screen, I can completely adjust that implant. You can see on that top left, there's actually a femur implant superimposed on the bone. And I can adjust exactly where it goes. And then I push the buttons. These are all live buttons on the bottom here. And I can adjust the size of the implant where it's going to fit. And then say go, hit that right arrow on the lower right, and the robot arm moves into position, and it lines me up, and I then go ahead and cut the bone, but it's very, very accurate. Go to the next screen for just a minute. This is our last one there. And this is how we collect some of the data. So we actually, in real time, as we're moving the knee, we can see the knee moving. This is a static picture. But as I move the knee and flex and extend it, it creates these graphs on the right of the actual ligaments in that patient. And I can then make adjustments in where we cut or how we do the surgery to balance them perfectly. So at the end of the surgery, all these numbers would be the same. They would all be about 11 millimeters. There would be no difference between them. So this is the knee robot type of system that we use. They're all very similar. I find them to be very accurate. What I like about it is, rather than me measuring and using rulers, I really can make a large number of measurements very rapidly. And that's really what I like about this system. So that's the way robotics works in orthopedics, very different than general surgery. We don't sit at a console, we're literally standing there next to the patient. So that's kind of an overview of what orthopedics looks like. And I think we can run to some of the other questions there.
Yeah, I think that was incredibly helpful. So thank you for taking that step back there. Just seeing, first off, the size surprised me. And then secondary, the ruler, that visual image of the ruler, and now just the accuracy, that you can achieve is really incredible.
Right, so that's the thing that attracted me to this. Now, robots are not used in 100% of orthopedic surgery now, and some doctors feel that they can do just as good a job with, the more conventional instruments that we use, because they're actually very advanced and very accurate. So, it's going to take us years to really sort of figure out how the robot fits in and where it's better. For me right now, I don't see any reason that it's worse. It certainly streamlines the surgery and gives me tremendous information, which, as somebody who studies total knees and writes papers on it and is very interested in outcomes, I find that it's a very useful adjunct to what I do. However, if you're seeing an orthopedic surgeon and he or she says, hey, I get great results with my standard instruments, as of today, it's more technology for the robot. I think there may be some advantages that we discover as we use this more, but I can't say to you, don't go to the doctor who doesn't use a robot, because there's a fair number of robots out there now, but it's nowhere near 25 or 30% of the knee replacements being done in the United States. It's starting to get close to that, but not quite there yet.
Absolutely. But more so just, educating yourself and having the conversation, which is what we're doing tonight. So thank you. Okay, let's dive into a few more questions we have, and then we'll go into our live questions in a bit. But let's talk about weight for a minute. Dr. Phu, is weight a factor when considering general robotic surgery?
Yes, weight and BMI is always a factor in any types of surgery, and I'm sure Dr. Starr can comment on that. The BMI is always a factor to consider. And in terms of robotic surgery for general surgeons, it is safe for obese patients. There can be, increased ergonomic advantage given by the robot, because the support of the robotic arms and the cart can support that weight. And it could be a good option for those body habitus. Studies have shown that there can be an increased time in the operation for larger patients because there can be additional need for retraction and mobilization. As well, for surgical planning, there may be additional port placements or additional instruments that are used. So yes, overall, the short answer is there can be increased decision making or other types of tools needed for obese patients.
Okay. And Dr. Starr, can you comment on whether weight is a factor for robotic surgery for knees and hips?
Yeah, it's not so much a factor for the robotic aspect of the surgery. The trend across the United States today, and BMI stands for body mass index, and it's a measure that we use relating height to weight. If you go on the various websites of things like Weight Watchers, they talk about this. But a lot of the trend for the last 3 or 4 years in orthopedics has been to try to optimize our patients, meaning reduce the risk. And the sense is that when you get over a BMI of about 40, Now, mind you, that's about 100 pounds overweight, that the risk starts to double and triple for these procedures, regardless of whether you do robotics or not. Robotics is a tool. You can use it in any patient. But I think what you have to understand is we're here talking today about a specific technology, robotics and general surgery and orthopedics. But in reality, that's just one small part of us. And we tend to have very extensive conversations with our patients. And I'm sure Dr. Phu can agree with this that if you're planning surgery on somebody and it's abdominal surgery and they're very, very heavy, that may provide physical impediments. Same for us. We struggle a little bit as the patients get larger, and the complexity parallels the complication rate, things like infections. Some people believe blood clots. So we really encourage our patients. We literally will send our patients to dietitians and nutritionists and see them ourselves and kind of monitor them through trying to lose some weight to optimize their surgery. But it's not a specific restriction for robotic surgery and orthopedics.
Okay.
Yeah, I echo Dr. Starr's comments. Funny you do say BMI of 40 because I usually have a cutoff of 40 as well for any sort of abdominal wall hernias. Complications and recurrence rates are higher for people higher than that weight because they can go up to 40 to 50% for recurrence rates for hernia repairs. So like Dr. Starr said, we try to optimize patients at those higher end weight levels before we proceed with surgery. And just like Dr. Starr said, it is a tool to perform surgery, but it's not the sole thing to make the only decision. There's other factors for the patients to consider.
Okay, well, thank you both for walking us through that. I'm going to continue the conversation and turn it a little bit to specifically knee surgery. That's certainly been a question we've been receiving a lot of. So, Dr. Starr, can this surgery be used for cartilage tears? And can this also be used for partial or total knee replacements?
Okay, so cartilage tears is really a different end of the world. And most of those are done arthroscopically where they can, little tiny incisions. There, as far as I know, and not that somebody isn't experimenting with this, not much role for robotics and cartilage tears. That's more soft tissue surgery, and they have a lot of techniques and gadgetry and very modern technology, but that would be more of a sports medicine or a cartilage restoration type of surgeon, which is not me. These robots that I'm using are very much dedicated to knee replacements, and to some extent, the hip replacement's not quite as popular with robotics. So it's very much, I actually started to use a robot, and the most popular robot was originally developed purely for partial knee replacements, which means a replacement. I showed you a full knee replacement, that's the whole knee. A partial knee replacement would be just one part. So that might be the back of the kneecap. It might be the inner part of your knee where your one knee touches the other, or the outer part. The accuracy of these has been felt by the developers to be very advantageous. Once again, everything's controversial. You ask different surgeons, you get a different story. But the original robot in this country that was the most popular was developed solely for partial knee replacements and then ultimately modified for total. And the advantages are slightly different between the two. But yes, those are the standard applications we use this for.
Okay, great. Thank you so much. All right, continuing along, Dr. Starr, another question for you. Will this surgery benefit people who are 65 years and older? And would you say, is there any age limit?
Okay, so the oldest person I've ever, first of all, we don't preferentially use the robot in younger versus older patients. I do the vast majority of my knee replacements robotically. But ages for knee replacements, the youngest person I've ever done a replacement was in their 20s, and the oldest person was 98. Now, obviously, we don't operate on a lot of 98-year-old people, but specific circumstances may dictate a very healthy person or someone who's terribly disabled by their arthritis, maybe where the bone has collapsed. That was the case that I happened to do. But no, I mean, in the last few weeks, I've done people 90s, 80s, 70s, 60s, 50s, and 40s. Wow. So it doesn't, unfortunately, arthritis doesn't respect age. The typical aging kind of arthritis that's occurring, 55, 65, 75, 85, 95. But, we see post-traumatic arthritis, someone who's had a bad fracture. We see people who are born with abnormal bones and their bones haven't developed properly. So we do replacements. Our team of orthopedic surgeons, and we have quite a number of them who do joint replacements, are people who operate on many different causes for arthritis and a very wide range of ages.
Okay, well, I think that is, promising to hear for people listening tonight. So thank you. All right,
Mm.
Dr. Fu, we'll go to you. Can this machine take care of hernias and gallstones? And for hernias, are there any limitations to how large or small the hernia is?
Sure. We'll bring those slides up. So just there's no limitations to how small the hernia is, but sort of like to address it earlier, I mean, there is a certain size of a hernia that may be too large for the robotic instruments, and that really is dependent on the size of the patient and the size of the hernia itself. But the first picture here is in reference to an inguinal hernia, and that is in the groin area. This is after the dissection, and the hernia sac has been reduced. And so the robotic arms have already done the precise cutting, reduction of the hernia sac, and clearing the spaces of all the hernia defects. And sort of that white looking, lattice looking is the mesh. And so that's placed across the myopectineal orifice to cover the hernia spaces. And at that point, the robotic instruments will allow me to suture the mesh in at certain points to anchor it to the bone. And then we sew the peritoneum up to close the hernia repair. And so that would be what we call a robotic inguinal hernia repair, transabdominal, where we go inside the abdominal cavity and do the fine dissection to reduce the hernia. Next slide. The other application is for gallbladder surgery. I know it's kind of hard to see amongst the green what's what, but you can sort of see this right in the middle, a sort of sac-like organ. That's the gallbladder. And it's very useful in gallbladder surgery because this green light here we see is a special sort of mode we call Firefly on the Da Vinci system. What happens is when we turn this on, it allows me to see the biliary anatomy, the bile ducts, and the gallbladder itself. It's a special type of dye that I inject before the surgery and helps absorb into the patient's blood. And so when the surgery happens, it gets excreted through the liver and the bile duct system. So it helps light up these bile ducts and helps us do a safer dissection when we're teasing out the tissues and finding the critical structures before we clip them. And so on the bottom here, kind of near the instruments, that's the cystic duct that we have to identify before clipping those structures before excising it. So those are the applications what can be used for inguinal hernias and gallbladder disease. And that was a specific application where it can be useful to help with safe dissection of the anatomy.
Hey, thank you so much. It's just incredibly helpful to kind of go through these visuals with you. So appreciate you walking us through that once again. Thank you. Okay, so a big question for the evening is centered around recovery. So, Dr. Fu, we'll start with you. How long does it take to recover from these surgeries? And are you able to be alone at home after?
Sure, yeah, the hernia surgeries, inguinals or ventral wall abdominal hernias are typically same-day surgeries when planned electively. We do them at Lansdale Hospital. The patient comes in, has a surgery done, and then usually goes home the same day. Somebody has to drive them there and back. It's okay to be alone at home, although I would recommend having a family or a family member or a friend come check up on you, once or twice over the next few days, just to make sure everything's okay and make sure your needs are met. But it should be okay at home. In terms of the recovery, my usual instructions for hernias patients is that no heavy lifting, more than 10 to 15 pounds for about 2 weeks, at which point I do see my patients in the office as a post-op check at the 2-week mark to make sure things are okay. After that, if things are good, they can increase their weight restrictions and limitations and lift heavy things as needed. The recovery, people ask about what I can eat. Usually it's just light food for the first day or two. Sometimes they can have nausea from anesthesia, but they can go back to their normal diet. Specifically for gallbladders, I tend to keep my patients overnight. And if things go well, I check them in the morning and then they go home immediately the next morning. So usually a short stay. And in terms of gallbladders, they stay on a low-fat diet for a few weeks until the body adapts to not having a gallbladder, and then they can try to transition back to their normal diet. But recovery should be usually straightforward.
Okay, thank you. And Dr. Starr, along those lines, could you maybe talk a little bit about the recovery time for knee surgeries?
Well, obviously, if we're talking specifically about knee replacement surgeries, the problem that we have in orthopedics is a lot of the things we operate on, you're walking on or you're using to lift heavy things. If you're just walking on your knee, you're using your body weight several fold over. So if you're, 150 pounds, depending upon how fast you're walking or whether you jump, you can get that up to several hundred pounds or several fold higher. Knee replacement surgery has become much better in the 50 or 60 years that we've had it. And it's all these additional techniques that have really helped us. So, when I started as a resident, we kept the patients in the hospital several days before surgery, and then they would stay in 2 to 3 weeks after surgery. If you go across the United States now, the trend is moving toward about a third of them as outpatients. So patients do go home. They generally have somebody there with them for a few days to make sure that they're okay. Because the problem we have is, unlike a hernia, you may have a difficulty walking, getting up because you're walking on the painful part. Generally speaking, our patients take some pain medicine for a few weeks, and we encourage them to do that to be comfortable. And they usually do physical therapy, many of them. There's some that don't need it, but it's often several months of physical therapy. So a knee replacement is a significant surgery. Now, having said that, it used to be quite uncomfortable. It used to be difficult to get through. I mean, we would see people still walking on walkers 3 months after surgery. And with the advent of better anesthetic techniques, our anesthesiologists are amazing. They block the pain with special injections, additional medications that have come on the market in recent years. So we give people a cocktail rather than one single medication. And the other thing is we do things preemptively. We do things before the pain comes. So what I would say to you is, I think compared with other kinds of surgery, a knee replacement is a significant surgery, and you should be prepared because there's a broad range of what people experience, everything from very little pain to a lot. But I would say that it's become much more tolerable. And our patients on average, even Pennsylvania is a little funny, they were late to adopt outpatient surgery legislatively, although it's moving very quickly now. But even before the legislation, our average length of stay for a knee replacement was something slightly over 1 day, which means basically people stayed one night and went home the next day. And now we're seeing many more going home same day. So, it's not something people should be quite as fearful of. We haven't 100% conquered the pain, but we're doing pretty well with it. It's not a ton of time in the hospital, but I only do half the job. Even with robotics and all these other techniques, the patient has to do 50% of the work. And the work simply means when you get home, move your knee, do things. We want you out and moving.
Okay, thank you. That was really helpful. And, I think promising for some people listening tonight. So thank you. Let's talk a little bit now about robotic surgery versus traditional surgery. I know we mentioned that earlier, but Dr. Starr, can you talk about the advantages or disadvantages to each? And maybe just about the cut. Is that just as large on the front of the knee or not? No, you just talked a little bit about recovery time, but maybe more so about, what that cut might look like.
Sure. So we have made our cuts a lot smaller from the 10, 12 inches that we used to use. And we've sort of, run the gamut with this because for a period of time, maybe about 15 years ago, everyone was competing to have the smallest cut, which of course is very cosmetic. So, the cuts got down to like 3.5 inches, and they've rested now at something closer to 4 or 5 inches for a lot of these replacements. The robot doesn't change that. It actually does. What I like about the robot is all the feedback, the potential for greater accuracy, not 100% proven, but there are a number of papers that suggest that the x-rays look better. Does that mean the patient does better? Not proven yet, but I think it's a promising technology that I like, but it doesn't really change the incision size because we're doing the exact same surgery, unlike when with laparoscopic, arthroscopic, and ultimately robotic general surgery. So I would like to be able to offer that as a big change. It's not. What we're focused more on is ligament balance, accuracy, and the belief is whether you talk about robotics or better mechanical instruments or other ways to do knee replacements, I really do truly believe that if we make this knee function much more like your original knee, not the one that was arthritic, but the one before it was arthritic, we're going to do better. And, there's a lot of philosophies on how to do that with, pressure transducers built into the implants and, all sorts of different things. For me, robotics is something that I'm very interested in. And as I've used it for a number of years now, I've been pleased that the kind of feedback I'm getting hopefully is going to translate, maybe not into a smaller incision, but hopefully into a better outcome in the long run for our patients in two ways: a knee that works better and one that lasts longer. So stay tuned because, I'm seeing the results now of knees that were done 20 years ago. It takes that long to really know because a knee replacement is not something you can just look at for a year or two. If a patient comes back in 3 years, says I need a new one, that's not a success. So we are kind of trying to lead into this newer technology. Once again, I have a bias, I like it, but that doesn't mean to say that what we're doing now isn't going to change over time.
Mm-hmm. Yeah, that's interesting that really you need 20 years to see how that recovery process goes almost. But,
yeah, I mean, a knee replacement can last easily 20 or 25 years. There was a paper 2 years ago that suggested roughly 80+% of knee replacements would still be working after 25 years, which is good news for some of those, 40s and 50s and 60s that we're now replacing their knees.
Exactly. Okay, great. Dr. Phu, what about hernia surgery or maybe other general surgeries where robotics can be used? Do you mind talking about the advantages and possibly disadvantages there?
Yeah, I mean, the Da Vinci surgical system is used in other different subspecialties besides general surgery. I mean, I think it started off as in cardiac world and also kind of went towards urology for prostates. That's their sort of biggest stake in where they established themselves. But they are, expanding and being in different subspecialties like gynecology and colorectal surgery as well. So you're seeing larger applications of the Da Vinci robot in different subspecialties as well. Just like compared to open traditional surgery, the robotic minimally invasive system does allow for small incisions and in turn, lesser risk of surgical site infections and less pain. So overall, using a smaller incision and smaller tools translates to quicker recovery and less pain.
Okay, great. All right, another question we've received quite a few times, and then I think we'll dive into the live questions because thank you all. We've been receiving a lot, so we're ready to get to that. But one question for you both, I'll start with you, Dr. Phu. How does the robot know how to do precision exact location cutting on the body? And maybe what would prepping the machine look like?
Yeah, it's a good question. I think people have this preconceived notion that it's sort of autonomous. And I think Dr. Starr, you can say the same thing. It's never autonomous. The surgeon is always in full control of the robotic system. It's not like, we're on the physician lounge and they're doing this job itself. We're always in full control. It just allows more accurate and precise dissection. It doesn't do any cutting on its own. Any movement that the robotic instrument does is translated from our movements in our hands to the wristed instruments. And so nothing is done without us telling it to do it one way or another. So suturing, cutting, cauterization, all those fine dissection and movements is directed by us. It's like as if I, translate, instead of doing open surgery, I shrunk my hands and my instruments and was inside the abdominal wall doing that surgery and having that same accuracy, but without a bigger cut. In terms of prepping it for the Da Vinci, Those big robotic arms, they are, covered in sterile drapes. The abdomen is prepped in the usual sterile fashion with an alcohol-based scrub. And so, the sterile procedure, as usual, is done for the robotic instruments as well to do this.
Okay, great. And Dr. Starr, anything you'd like to add there?
Well, I mean, obviously every system's a little different. There are multiple robotic systems. The sort of history of robotics in the world was a system called Robodoc, which actually was an autonomous robot, meaning you set it up, put it in position, and turned it on, and you made all the adjustments. But then once you turned it on, it would kind of move in and out of the bone and make the machine the bone the way you want it. That isn't really very popular right now, and all of the current robotic offerings, you kind of think about it like drawing a laser line. If I can take a computer, measure your knee very accurately, and then ask the computer to show me where to make the cut in the bone to get the implant exactly where I want it. But in the case of these robots, they use a robotic arm. So basically, there's no laser. It's all the visual cues are done through those cameras, so you can't really see any laser lines. But when I say, okay, I want to start to make the cuts for the different implants in the bone to get them in perfect position, the robot actually moves the saw into position and kind of hands it to me. And then when I'm making the cut, it stays in alignment based upon where the robot determines it should be. But remember, and I think Dr. Phu said this very, very clearly, we control that. I mean, what I put on the screen, the robot gives me information, but I have to program into the screen where it's going to go. So there's, this, and when we start talking about, one of the worries people have is we're actually writing a paper on this now. Our patients concerned that the robot's going to take the control away from the surgeon. The goal of the robot is to provide more control for the surgeon. And I think that's true of both of these systems. Similarly, there's a robot for spine, same thing. It's meant to, and I'm not going to say that it can do it better than a surgeon who's very experienced, because as we know, some surgeons prefer to do without. But the idea is to provide an increased potential for accuracy for any surgeon who's doing this procedure. So, like I said, does that mean you should run out and find somebody who's doing robotic surgery tomorrow? No, I mean, I think there's different options, but we do offer this procedure, and there really are no limitations to the procedure. To us, a knee replacement is a knee replacement. The robot, just like some of these mechanical, very fancy instruments that have been developed over the years, are meant to allow us to adapt what we want to do to the patient's anatomy. So, we talk about this being very patient-centered, which is actually our approach overall at Abington and Lansdale hospitals. We kind of advertise ourselves as patient-centered care, meaning, how we treat you when you're in the hospital or when you're coming in and out for your surgery, but just as importantly, how we treat your knee when we're doing the surgery. We don't want to make everybody's knee look the same. We want your knee to look like what your knee is supposed to look like.
Okay,
if
great.
That makes sense.
Yes, that's terrific, and an interesting point about wanting to just bring more control. The surgeon's not getting less control. If anything, it's more. So, yeah, a really interesting point there. Thank you. Okay, so we've been receiving a ton of great questions. So I just want to dive into the live questions now, if you both are ready for that. So we will kick it off. I think, Dr. Starr, this one is for you, but Dr. Phu, feel free to jump in. We'll have this be a fun live conversation. But the first question for you, I need double total knee replacements. What's the big advantage of robotic? The Rothman surgeon I am working with said he does both, offers both, but would rather do surgery himself. And just wants your thoughts. I know you kind of mentioned this before, but anything you want to add there?
Well, I mean, first of all, double knee replacements. This is the first time that's been mentioned. That means doing two knee replacements at once, which is a perfectly reasonable technique for a healthy person. Obviously, you don't want to prolong surgery in someone who has a lot of health issues, but double knee replacements are accepted in this country. It is, you're having two surgeries in one day, and you have the discomfort of two surgeries in one day. So that's really the the part of it, and that's not really the topic for tonight, but that's something to think about. What's the big advantage of robotic? I think I already covered. We're learning more about robotic. Now, one of the robotic systems I've used, we've had for over 5 years. So we have a lot of experience with it. But remember what I said, looking at knee replacements, you have to look at them over a very long period of time. So I would say that the checkup on robotics right now says that it seems pretty good. It certainly seems equivalent, in my opinion, to other ways of doing surgery. And now we have to wait and see, who wins the race. I'm very positive on the robots, but that race is ongoing. Now, you mentioned in your question, you're working with a surgeon who says both, but prefers to do the surgery mechanically, meaning with the standard instruments that he or she trained on. And I always say to patients, if you have somebody you have confidence in, don't try to change what they do. So I think I love when patients come in and they've been on the internet. It drives some doctors crazy, but I think it never hurts to have a lot of information. But fundamentally, the thing you always want to think about is you're seeing a surgeon based upon their reputation, the way they speak to you, do they answer your questions? Can you work with them? That's your decision. Now, if you have in your brain that, you've read about robotics, just like any other technology, and you really want that, then find somebody who really is in favor of that. They will support you properly. But I really would tell people, hesitate. You're seeing a great surgeon who has a great reputation doing the surgery in the way that they do it. If you want them to do your surgery, I mean, I know I've had several surgeries. I always look at the surgeon and say, look, I'm not here to make the decisions and tell you what to do. I'm a doctor, but just forget that. Because, if I'm coming in here to get my shoulder fixed, you know more about that than I do. I'm a knee and hip surgeon. Do the thing that you are the most comfortable doing. So I think the one thing I would really point out, and I think we would all agree on this, doctors do particular kinds of surgery because it's what they're comfortable with and they think they can get a very good result. That may be a robot for one surgeon and not for another. And I think that the general public needs to understand that until we get to the point where we can prove beyond a shadow of a doubt in the orthopedic world that a robot is better. You've got a lot of good information out there, referrals from your medical doctors, patients in the community, reputations, many things like that. That should be your golden, evaluation. And the other parts should be really, things to talk about and decide how important they are to you. Does that make sense?
I think that makes total sense. Thank you for
Thank
outlining
you.
that. Yeah. Sticking with, at the end of the day, your physician has to stick with what he or she feels best doing.
I mean, Dr. Phu, do you find that? I mean, do you see that, some people kind of get pushed into, hey, I really want robotics and, this isn't something you obviously do a lot of it, but, do you hear this from other folks and what's your thoughts on that?
Yeah, you do have patients come in and do a lot of research, and I do really appreciate that they come in educated and knowledgeable. And if they're appropriate for, minimally invasive surgery or robotic surgery, then, I will offer that to them. But sometimes, patients come in with unrealistic expectations with the types of pathologies that they have, or, a different type of hernia, and they wonder if we can have robotics, or and it says that's not appropriate for this tool. And so then we kind of have to realize and reset their expectations. But yeah, Dr. Starr, I agree. We have patients that come in that want one certain thing, but you have to understand the patients and their medical history may prohibit them from having that type of technology be used.
Okay, thank you both. All right, Dr. Phu, let's give a question for you. What is the purpose of the gallbladder? That's a good question. And how
Yeah.
do we live without one?
Yeah, I get that asked a lot when we talk about cholecystectomies. And the purpose of the gallbladder, I say it's like a little plum-shaped organ that sits underneath your liver on the right side of your rib cage. It's a storage facility for bile. Bile is a green liquid that's made by your liver. It contains bilirubin, cholesterol, lecithin, all the salts, and it goes through the bile ducts to be excreted into your stomach, and it mixes up with the fats of the foods to help digest your diet. And so your gallbladder is just a reservoir. So any more bile that your liver makes that you don't need, it gets just stored in there. The gallbladder can develop stones, and about 20 million Americans get gallstones, but not everybody becomes symptomatic from them. They form because of weight gain, rapid weight loss, pregnancy. There can be a genetic component as well, and so stones can form only when they become symptomatic, when they can get lodged into the neck of the gallbladder. Is at the point where cholecystectomy should be discussed, because it can cause biliary colic, where you have pain that occurs at night or after meals, or cholecystitis, where you have an infection of the gallbladder, where the stone is really lodged into the neck and it gets stuck and you get an infected gallbladder. So it does have a purpose. It does hold a reservoir for bile to digest your foods. You're no less of a person without one. So when you look at a diagram of a gallbladder to the liver, when you do take it out, you still have the remaining of your biliary anatomy to your liver to continue making bile and digest your foods, although your capacity to digest fats may not be as good as before, but your body usually adapts pretty well afterwards.
Okay, thank you so much. Very helpful there. All right, turning back to Dr. Starr, kind of looking into the future here, do you foresee shoulder replacements ever being done robotically?
Yeah, I don't think there's any question that, all of these sort of technical procedures are going to come up with more technical solutions. So many things we do are going to become adapted to these hopefully more accurate ways of doing them. So, when I look at robotics, what are things that are going to be done that way? Shoulder replacements, absolutely. Shoulder replacements, a little tough to do the socket part, and get it in perfect position. So I know several shoulder surgeons who are already kind of dabbling with this and trying to find ways. The other one is some of the sports medicine surgeons, where they're attaching ligaments and repairing ligaments and putting new ligaments in. I think they would really benefit from using some sort of high-tech guidance. And it may not be a robot, it may be a part of a robot, but to put these things in the proper location. So remember, in orthopedic surgery, we're dealing with bones and ligaments and tendons quite a lot, and cartilage, and we have to put things in very reliable locations. So anything that you need to put in a location, certain pins, screws, wires, anchors, we call them, which we anchor tendons to, can all benefit from this type of a technology. Now, why don't we have them for those things yet? Well, it's a numbers game. These machines are very expensive to develop and to purchase. And knee replacements and hip replacements, which were the first two applications for the robot, and now spine surgery, we do well over 1 million knee and hip replacements in the United States a year. Spine surgery is very popular, and the accuracy there is very critical. So once again, these are in development. There currently are spine robots, knee robots, some limited hip robots. They're available, but they're not used quite as much for some technical reasons. But basically, we're going to see this continue to blossom. And I think it's going to be like, many other technical things, like a cell phone, things that cost a ton of money before. Once we kind of figure this out, add things like virtual reality, augmented reality, machine learning, ways for the machine to help make the decisions, which sounds a little scary, but actually I think can be helpful. You're going to see that all over the place. And, our operating rooms 20, 25 years from now are probably not going to look anything like what we have now. My guess is, Dr. Phu will be sitting, with a little video game console that's maybe the size of an iPad, and the thing by the patient will be, a tenth that size, because, everything's miniaturization, everything is, faster computers. So, I think the future is very bright, but, we're working our way through that.
All right. Hey, that sounds pretty fun. A little iPad doing surgery. We'll see.
That sounds pretty cool, Dr. Starr. We'll see what surgery is like in 20, 25 years.
Right, exactly.
We'll see. Okay, I know we're a little bit over here, but we'll stay on until 8:15, just because we've been receiving a ton of great questions, if that works for you both. So let's just take a few more here. Okay, another question about knee surgery for you, Dr. Starr. Is there less soreness and recovery from robotic knee surgery?
Well, that's kind of the holy grail. Some people say yes, some people say no. There's only one or two credible papers or papers in production that really look at that issue specifically and show a difference. But of course, you're looking at many different types of robots, and you're looking at the evolution from something that was less sophisticated years ago to something now that's probably more sophisticated and looks at more aspects of the knee. Just kind of like any computer system. When you first got a computer system, it could sort of look at a few different things, kind of like go back to the old video games from 30, 40, 50 years ago. They were so simple. Now they're once again, they're virtual reality things. You feel like you're actually in the scene when you're playing the video game. Our computers are getting like that as well. So I think right now we're still trying to prove that having a better balanced knee, having a more accurate knee ultimately will lead to getting your range of motion back faster, not having as much pain, being able to walk more quickly and get back to activity more quickly. There's a promise of that. We're not there yet to be able to say that 100%. But I think through the development of these technologies, we will ultimately be able to, offer that type of result. We're getting there. I think, the miniaturization part of it, which we don't have in the knee replacement right now, meaning we still use big incisions, you're really going to have to remake that big knee replacement, find a different kind of way of doing it completely from start to finish, as compared to the general surgery robot where it really is you saw that big machine, but it amounts to a couple of little holes and much less, abusive sort of dissection. So I think that probably, and Dr. Phu should weigh in on this, probably the general surgery robot is probably more there. The total knee robot is probably I think it's a good offering now, certainly as good as mechanical instruments, but it's looking more to the future to really be able to say some of those things.
Yeah, Dr. Starr. I think the Da Vinci system has been around for about 20 years. I think it's really gained traction in the last 10, and filtering to the general surgical field, and it's being more advanced and established in the minimally invasive techniques that it does offer. I think surgeons are starting to see the benefits of it and the benefits of the surgeon itself in terms of ergonomics. And the articulation, the finer dissection. So I do see it as an advancement of a type of minimally invasive surgery, sort of like the next level of laparoscopy that's developed. And I think it's here to stay. There's been iterations of this before, where they single site and natural orifice surgery. They've come and go. But I think it looks like the robot's kind of here to stay. And you can see other surgical systems besides Da Vinci. There's other market players that are sort of coming into the field, from Medtronic and Johnson Johnson. They're all having their own versions of it. But it's the same idea of having these sort of small instruments to do procedures.
And I want to do one disclaimer. So a lot of times my patients come into the office and I like to chat with them about it. And I always say to them, be careful, because I have a tendency to geek out a little bit on these robots and start talking about, tissue tensions and lengths of ligaments and things like that, and different kinds of computer processors. But, I'm a very big advocate. They'll say to me, well, I listened to your talk, because I've done many of these, and you don't sound like you're really saying, go ahead and have a robotic knee replacement. I believe in the technology, and I believe in it because I like the feedback that I receive. I think in general surgery, they can probably quote more results. In orthopedic surgery, I think it's a promise of where we're heading. And I really do feel like it gives me the most possible feedback as I'm doing the surgery. But I'm very careful to say, look, what I feel and what I see in the operating room myself personally is not enough for me to say to you, yes, every patient should have a robotic knee replacement. I think it's frankly quite amazing technology, but we really need to have the studies, which are in the works, to really be able to say, you know what, this is really a better way to do this. So I think it's very attractive. And I do think we're eventually going to prove that this is something that's better. But the question is that going to be this version or a version down in the future? You know, I'm pretty optimistic, but I think from an honesty standpoint, we must tell our audience, you know, if you're seeing a great knee replacement surgeon who does their technique that they've been doing for a number of years and gets great results, you know, don't go running to see somebody else just because the word robot or the word laser or something is in the description. It's up to us. You know, we have to use these things and get very proficient with them. And then it's up to us to prove to you as the public that this is what you should have every time.
Okay, thank you. That was incredibly helpful. Appreciate it. All right, let's take one or two more questions and then we'll close out this evening. A quick question, very specific, just relating to weight. This person says they weigh around 350 pounds and they just want to know how much weight should they lose before having knee surgery?
Well, it requires a ratio of weight to height, and Dr. Phu mentioned this BMI concept, body mass index. So in the United States today, the majority of orthopedic surgeons, I believe, are consistent with a BMI. So you can look up your height and your weight and figure this out right on the internet. But if we like to see you get that BMI down below 40. Now, if you kind of look at the statistics, over a BMI of 40, your risk of a problem, a serious problem, goes up and doubles. Now you have to kind of decide, you know, just being slightly overweight with like a BMI of 29 or 30 is equivalent to being perfect weight. And then from 30 to 40, you know, that number starts to go to the extent of doubling. So what I would say to you is it depends how much you want to be sure that your replacement works very well and you don't have a complication. If you really want to get to a level that's very, very safe, that's maximally safe, then get down to a BMI of 30 or less. We kind of, in our group, we have agreed that we won't do people over 40. We'd like to see them lose weight first. Some folks use 38, but that seems to be the range of what we see. So I think those give you some sort of rough guidelines without, you know, sharing personal information and trying to do that. But those numbers are on the internet. And, you know, if you're 6'6" and 350, you're probably pretty close. If you're, you know, 5'4" and 350, it's quite different.
Okay, thank you. All right, one last question for tonight for you, Dr. Phu. We'll close it out. Okay, this is, how is the size of a hiatal, sorry if I'm mispronouncing that, hernia determined, and if it's moderate or too large for robotic surgery?
Good question. So hiatal hernia, I think that's what they're referring to. It's a different type of hernia. It's not an abdominal wall hernia where it sort of sticks out and you can see it. A hiatal hernia is a type of hernia through the diaphragm muscles where your esophagus goes through, just when it turns from your esophagus into your stomach. And so that little opening of the crus near your diaphragm can enlarge over time for all sorts of reasons, but you can get a hernia through that. Now, I guess the question was asking, how do you measure how big it is? You can quantify it on a CT scan of the chest and the abdomen and do measurements on the CT scan, but you can get a sense, is it small or is there like different organs in there? Is like most of your stomach in there and how much it extends into your chest or the thorax? I can give you a sense of how big it is. And sometimes it can be diagnosed on an upper endoscopy too as well, where they look inside the stomach and see how big it is from the inside of the stomach. And then was the second part of the question, can it be repaired robotically? Yeah, exactly. I'm that's not my specialty, but I do know surgeons who do that. And so, you know, hiatal hernias are possibly repairable through the Da Vinci system as well. And it just depends on sort of the size and the complexity of the hiatal hernia itself. And sometimes if it's, you know, not approachable with a robot, it may need to be, you know, done through the chest or maybe through abdominal incision. So it depends on the size and the complexity. But yes, the robot can be an option.
Okay, well, thank you so much. I just want to give time for some final comments before we close it out. So Dr. Starr, we'll start with you. Any final comments you would like to leave with our audience tonight?
Sure. I mean, I think that first of all, it's been our pleasure to be here tonight. I really enjoy talking to people about this. I mean, this is literally what I do all day long in the office. But it's fun to be able to sort of talk in a general way to a larger group of people. I think, some of the comments that, that both Dr. Fu and I have made, which are very general, may not apply specifically to you. And I think you always have to be careful of that. But more importantly, find somebody that you have confidence in to work with. Don't be afraid to ask questions. Don't be afraid to look on the internet. That's the way people find information out today. It's not all correct. So, don't be shocked if a surgeon says to you, well, yeah, that's something you may find, but that's actually quite old. There's newer things. But it really comes down to, don't be afraid to be a part of the conversation. And hopefully, if you need help, we're here to help you. And you find somebody that you really like and feel you have tremendous confidence in. So once again, have a great night, everybody, and thanks for listening.
Thank you so much. Okay, and Dr. Fu, any final comments?
Yeah, my honor to be able to talk to the community tonight about robotic surgery, and always a pleasure to have Dr. Starr here to talk about robotic surgery. And just to echo his comments, always do your research. Don't be afraid to ask questions and have second opinions as well if you desire. As long as you're comfortable with the surgeon, that's the most important part. And just realize, robotic surgery, whether it's orthopedics or general surgery or anything related, it's just another tool that the surgeon can use to help take care of patients and provide good outcomes. And ultimately, that's our goal at the end, is to take good care of our patients. That's what we all want.
Absolutely. Okay, well, thank you so much, both Dr. Fu and Dr. Starr, for your time this evening. Such a great amount of information was shared about this topic, and we really appreciate you attending and just submitting such engaging, wonderful questions. I know I learned a lot myself. We will be posting a post-event survey, so you can let us know your thoughts. Was this helpful? Is there another time that works better for you? Any other specialties you would like to hear from? Your feedback will help us bring more virtual events like this to you, the patients. Please be sure to visit the new jeffersonhealth.org website to stay up to date on upcoming classes, events, and webinars just like this one. A recording of this event will also be sent so you can rewatch. And if you would like to view other wellness webinar series events, please visit our Jefferson Health YouTube channel. Now, if there is anything anyone here at Jefferson can do for you in this time of need, please feel free to reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful night.